Good morning, everyone. My name's Ali Damji, and I'm one of the co-moderators for the COVID-19 Community of Practice. I'm a family physician from the Credit Valley Family Health Team and the Division Head of Primary Care at Trillium Health Partners. We're really pleased to be partnering between the Department of Family and Community Medicine at the University of Toronto and the OCFP to provide these sessions, and this is our 55th session. And Happy New Year to you all as well. I'm going to turn things over to the OCFP President, Mekalai.
Thank you, Ali. And good morning, everyone. Thanks so much for being here today. I'll just take a moment to thank our panelists. We know we couldn't do these sessions without them. And a quick reminder that this is a Main Pro accredited session. You'll receive more details by email afterwards. Next slide. So moving on to our land acknowledgement, we acknowledge that the lands on which we are hosting this meeting include the traditional territories of many nations. The OCFP and DFCM recognize that the many injustices experienced by the Indigenous people of what we now call Canada continue to affect their health and well-being. The OCFP and DFCM respect that Indigenous people have rich cultural and traditional practices that have been known to improve health outcomes. I invite all of us to reflect on the territories we are calling in from as we commit to gaining knowledge, forging a new culturally safe relationship, and contributing to reconciliation. And I'm calling in from Kitchener, the lands traditionally used by the Haudenosaunee, the Anishinaabe, and the Neutral peoples. Next slide. So I wanted to take a moment to reflect after our land acknowledgement, and again, just recognize the injustices that Indigenous people have faced as a result of colonization. And we know that this has happened in healthcare as well. So this is an opinion piece that was in the Globe in the fall, and it was written at a time when we were facing quite a surge in respiratory viruses, and you probably recall also a shortage of antipyretics for kids. So this article references a memo that was sent out to remote and northern Indigenous communities where staff were advised to keep expired antipyretics on hand in the event that they needed to be used. And I think what's key here is this was actually a different recommendation than what was made elsewhere in Ontario. So for me, as I reflected on this article, just reminded me that there is room for continued learning and growth as we think about how we are providing healthcare to our Indigenous populations. And just important for us to be mindful of the inequities that Indigenous people have faced and at times continue to face in healthcare. Next slide.
Thank you, Dr. Kumanan. So for today's session, this session is Main Pro accredited, and we do provide recordings of these sessions as well that are posted on our website. They're typically posted shortly after the session as well. Next slide. We have a wonderful panel joining us today to speak about therapeutics, and really thrilled to have them all here. Next slide. So I'm going to turn things over to each panelist in turn to briefly introduce themselves, starting with Dr. Andrew Pinto.
Thank you and good morning. My name's Andrew Pinto. I'm a family physician practicing in Toronto and a public health specialist and direct a research team called the Upstream Lab. I also have a role around supporting clinical trials in primary care in Canada.
Thank you so much, Dr. Pinto. Next slide. Next over to you, Dr. Evans.
Hi, Gerald Evans. I'm an infectious disease physician working at Kingston Health Sciences Center and a professor at Queen's University, and a member of the now defunct and retired Ontario COVID-19 Science Advisory Table. I'm really happy to be back and participating again in this particular event.
Thank you. Next over to you, Benita.
Thank you, Ali. I'm Benita Hosseini. I'm one of the scientists at Upstream Lab, and I help to support CAN-treat COVID study.
Thank you. And to you, Norm.
Morning, everyone. My name is Norm Umali. I'm currently a pharmacist with Andrew's team at the CAN-treat COVID project.
Thank you. Next slide. Over to you, Mekalai.
Hi again, everyone. My name is Mekalai Kumanan. I am a family doctor in Cambridge, and I'm the president of the Ontario College of Family Physicians. I receive a stipend for that role, and I also receive a stipend for my role as chief of family medicine at the Cambridge Memorial Hospital, neither of which poses a conflict for today.
Thank you. And Liz?
Hi, everyone. Liz Mugga, family doctor from Ottawa, and I am the Senior Clinical Advisor in Primary Care for Ontario Health. Really great to be here. Happy New Year.
Thank you. For myself, no financial disclosures for me. And over to you, Tara.
I'm Tara Kieran. I'm a family doctor at St. Michael's Hospital and the Vice Chair for Quality and Innovation at our Department of Family and Community Medicine at the University of Toronto. And I'm lucky to have some salary support and had some grants, and none of these pose a conflict for today.
Thank you. So as we mentioned, today's session is going to be focused on providing a COVID update, as well as an overview of outpatient COVID therapeutics, including a randomized controlled trial. And in terms of our session, it's really important for us to have an interactive session today. So please use the question and answer function. And remember that you can press the thumbs up button to upvote other people's questions. So before you submit one, just check to see if there may be a question that's similar to your own and consider upvoting that question, so we can get through as many of them as possible. And then for the chat, feel free to use that as well to share your reactions or other comments. But remember, if you have a question, please put it in the Q&A so that way Dr. Kieran and I can find it. Next slide. All right, so again, really looking forward to our panelists today. And if we can go to the next slide. And we'll turn things over first to Dr. Evans.
All right, thanks very much, Ali. Sorry, I always have to poke a little bit of fun at this, and this is, of course, a little bit of the anticipation of what are we going to see this year. This has been an interesting thing. I was actually quoted once in the New York Times as saying, when you've seen one pandemic, you've seen one pandemic. So let's get a little update on what's happening here in Ontario. Next slide, please. So reporting data has been a little bit sparse, but fortunately, yesterday there was a bit of an update to the data catalog for COVID here in Ontario. So right now we're seeing, as of about a week ago, around 900 new cases per day of COVID here in the province of Ontario. If you can recall, you can probably take that number, multiply by either 5 or 10 to get the actual number of active cases. Next slide. In terms of hospitalization ICU occupancy, you can see that we did dip down during the month of December. Almost certainly, I'm going to suggest to you that that was because of the flu, with the number of hospitalizations. A lot of that too, of course, is the holiday period where we discharge people as much as possible to get them home for the holidays. But we've seen this jump now over the last few weeks, up to around 1,500 people in hospital at any given time. And the ICU numbers, although they had dropped to just over 100 and are now up closer to 120 where they've been for a while, but nowhere near the peak that we saw of the 7th wave back here in October. Next slide. Test positivity continues to sort of hover in the range where we would suggest that the community prevalence is high. The two lines you see here, the red horizontal line and the green horizontal line, represent my view of where community prevalence lies. If it's above 15%, you're looking at fairly high prevalence. Below 15 and above 7.5, it's moderate, and below 7.5, it's actually quite low. And you can see here now, with the last reading that we have, we're down just below 15%. But we have been hovering above 15 at certain times, and certainly haven't gone below 7.5. Next slide, please. Wastewater detection continues to be an important tool for us. It gives us an idea of where things are sitting and can tell us where things are going in the next 5 to 7 days. And you can see here that with a peak that we saw probably related to the holiday period, that's begun to drop off across the province. However, there are variations amongst regions. Where I am here in the eastern region, in fact, those numbers are rising a little bit. Next slide, please. Variants are always important to watch, and we're going to have a little discussion here about XBB.1.5, but this is the most recent genomic testing that we have from the very last part of December. And you can see here that principally around 80% or so of isolates are either BF lineage, you can see here in a blue turquoise, the BQ lineage in purple, and then way down here at the bottom, you can see the XBB.1 and XBB.1.5 contribution, which is rising. Green here is the old BA5 lineage, which drove most of the wave 7. And then the other lineages are BA1 and 2, which are really disappearing now. Next slide, please. So everybody's interested in XBB.1.5. So what is it about XBB.1.5 that really is interesting? Well, I mean, first thing to point out is that it's a recombinant. It's actually not just a simple evolution of a subvariant, but actually a recombinant of two BA2 subvariants. And it has a very specific mutation, an F486P, which is the replacement of a phenylalanine with a proline at a 486 position in the spike protein code. And that's really important because at that point, a lot of antibodies target the area where that change is occurring. And so there's going to be an altered affinity for antibodies, and you're going to get what we call antibody evasion to some extent. So neutralizing antibodies that you have against some other variants may not be as good at neutralizing XBB.1.5, but that's really an in vitro effect at the moment. The other thing that's interesting and unfortunate about this is this mutation also drives the virus to bind much more strongly to the ACE2 receptor, which is the cell surface receptor in humans that the coronavirus uses to attach. So it's possible and speculated that a smaller inoculum of an XBB.1.5 virus may be able to efficiently end up transmitting COVID to a susceptible individual. And that's where you hear all this thing about increasing transmission, but really important to note that that's yet to be completely proven. It's probably legitimate and it's probably going to be important. Next slide, please. So the other thing about XBB.1.5, like many emerging variants and subvariants we've seen, is it has a significant growth rate advantage. Using BQ.1.1, which is the current dominant subvariant we're seeing here in Ontario, XBB.1.5 has a relative growth rate 2.5 times what we see with BQ.1.1, which tells us and can predict for us, next slide please, that if you look through into January, purple here, and this is a nowcast model that was done by the Public Health Lab here in Ontario. There's BQ.1.1. I think you guys can see my arrow moving there. It's peaked and dropping, but XBB.1.5 is going to really take off. So probably by the time we get into the sort of mid-winter to late winter, XBB.1.5 is going to be the dominant strain. Next slide, please. The other, of course, chief thing that we're looking at now is COVID in China. As everyone knows, they abandoned their zero COVID policy, but unfortunately, we have very little data coming out of China. We had one report last week that they had around 60,000 COVID-related deaths, but they're being very, very tight about the definition. So you have to have been proven to die of COVID and not die of your heart failure, which was exacerbated by COVID. So you can imagine that that's a little bit of an odd way to look at things. And we know from on the ground observations that higher numbers of hospitalizations and deaths are occurring in China. So it really is certainly taking off in China and is probably peaking at the moment. Next slide. Variants in China at the moment is our big worry right now. This is just the most recent data that we have from 11th of January that was submitted to GISAID, which shows us that the dominant variants and subvariants are BF7, BA52, and BQ1. So kind of like what we have here in Ontario. But that kind of data is not coming out particularly well. This is actually some data from from Eurosurveillance, which is a journal which reports on lots of important epidemiologic data. Next slide, please. The other challenge we have with, next slide, please. There we go. The other challenge we have is we know the vaccination rates in China, particularly in the elderly, are not as good as we'd like to see. This is the most recent data that was released by the Chinese National Health Commission, which shows that about 40% of their over 80s have had at least a booster dose. But, you know, this leaves a fairly large swath of individuals who are highly susceptible to severe disease. Next slide. Very quickly, I want to mention this because I get asked about this a lot. Viral interference is a real thing. When you have one viral infection, it's really hard for another virus to establish itself. This has been well known for years, and it's been demonstrated at cellular levels within host and population levels. And I want to show you what this year's seasonal influenza rise did to COVID-19. Next slide, please. So this is just a curve. This is Southeast Ontario data because I have access to very detailed data on test positivity here in the Southeast. And what you can see here in blue is influenza test positivity, which peaked in early December, just under 20%. What happened though, as influenza rose, COVID dropped off. And this is really the effect of viral interference. It's not a profound effect, but it does reduce the overall effect of COVID. And as influenza dropped off through December into January, you can see that COVID basically took off. So maybe it's another virus. Let's have a look at the next slide. So this is RSV and COVID, and you can see here that RSV kind of stayed fairly constant. It didn't really have any relationship to COVID. So one of the things that we do know even before we had the seasonal flu outbreak is that influenza virus does interfere with SARS-CoV-2 infection in animal models. So some of this drop in COVID, now the rise in COVID, is actually due to that sort of seasonal wave of influenza. Next slide. So just finishing off, lots of discussion about the role of bivalent COVID-19 vaccines. This is just some accumulated data that was published by on Twitter. You can see I took it from Eric Topol's Twitter feed, but he makes these nice graphs, makes it easy for me to make slides. And what you can see here is the bivalents actually have a substantial increase in neutralizing antibodies against XBB. Now, this is not XBB.1.5 particularly, but XBB.1. And this suggests that although there's going to be a diminishment with some antibody evasion, actually the vaccines still result in an increase, which is likely to have an effect on reducing some of the severity of disease and potentially even some acquisition of disease, even with XBB dominating with the bivalent vaccines. This is a BA.5 booster that was used. You hear the references, some of them, of course, are preprints. And then my last slide is the next one, just to sort of show you that if you measure this, and just be very careful here, the units are very small, but essentially you can see when you compare bivalents in this turquoise color to no bivalent, there is a substantial continued improvement in terms of the effectiveness as measured by the reduction in infection. So bivalent vaccines are really still the key to go. Lots of recommendations are out there from NACI, and we can talk a little bit more about that in the Q&A. So I'm going to stop at that point.
Thank you so much, Gerald, for that really informative talk. So in terms of the Q&A, I'm noticing people are putting in some great questions, which is fantastic. The only thing that I'm just going to mention is the Paxlovid and therapeutics questions. We're going to hold off on those for Dr. Pinto and his team, but we're going to ask some of the questions that are more related to the prevalence of COVID and the vaccines for you, Gerald. And so the first question is regarding concerns with the bivalent vaccine in the elderly. Is there anything that you could comment on regarding that?
Well, I think that probably is generated by the fact that the vaccine data link system that CDC runs recently reported that there was seemingly a small increase in ischemic stroke seen in people over the age 65 who got the Pfizer bivalent vaccine. I have to point out that if you look at all of their data, though, you look at the vaccine adverse effects reports, you look at the Veterans Administration reporting on adverse events with the vaccine, this signal's not been seen anywhere else. So we're paying very close attention to it. I think really this is an effect of the usual sort of, I don't want to say serendipity, but coincidences that occur when older people tend to have strokes. And so it's very possible that you can see a bit of an increased signal in strokes, but it may not be related to the vaccine. But we are paying attention to it. And at the moment, it hasn't changed any recommendations about getting bivalent vaccines, including the one from Pfizer, which I think is still strongly recommended for older people, because we know this disease is primarily one which affects older individuals.
Thank you. The next question's a bit of an interesting one. I guess it's related to, maybe some data discrepancies that are being seen. So one of the members of the audience is talking about how, they're looking at Ontario data and they're finding that the rates of COVID seem to be going down. But then the data that was just presented seems to show that it is going up. So are there some discrepancies that you're finding in the data at this point?
Well, the data certainly looks really funny. If you're looking at active case reports, every 1 week start, it drops and then it rises. And I think it's because of the way they're removing people from the data as active cases. So you're not getting that nice smooth line, but rather what looks like a sawtooth pattern. I don't think there's any question. We've had this probably peak of BQ1 and BQ11. That's happened, and I think we are diminishing. But now we're waiting and going to anticipate what is going to happen with XBB.1.5. So the person asking the question, it's a very valid observation. It is really challenging nowadays. The data is not flowing as regularly and as consistently as it did in the past. And so we have to be able to try and sort of interpret that. But yeah, it is looking a little bit funny, but in general, right now, cases are diminishing.
Thank you for that clarification. So this next question is about a case presentation. So the question is, has anyone come across patients testing positive on a rapid antigen test without actually having COVID? And they described that they had a patient who was positive for 17 days with no symptoms and tested positive 3 months later for 9 days with no symptoms. No one was sick around them, and they are good mask wearers. They had 3 doses of the vaccine, and the last one was about a year ago. So really, I guess the heart of that question is, can people test positive without actually having COVID?
Yeah, you can actually, of course, because everyone knows your illness, and this is familiar to all of us on this call. Your illness is due to your host response to the virus. And some people seem to be able to respond to the virus without necessarily initiating a huge cascade of inflammatory markers and inflammatory cytokines and lymphokines, which result in illness presentation. Asymptomatic presentations of COVID have been described since the beginning of the pandemic. The fact that the antigen test was positive is not surprising, because it is measuring just a viral product. It's not really measuring something that the host is producing. It would be interesting to look at those people serologically. So that clearly happens, and that happens with a lot of different viruses. You can get them and not actually get sick. And everybody's familiar with even bacteria that you can acquire that you don't get sick from. So not a surprise, but very interesting, and stuff that's continuing to be examined in genomics, because we want to understand why some people get this virus and they don't get sick. Some people get this virus and die. So.
And then I guess just to clarify with this question, would you say then that if someone has a positive rapid antigen test, that would mean that they still have COVID, right? It wouldn't necessarily be a false positive, or are there possibilities of there being false positives?
There is a possibility for false positives. Actually, one of the things that reminds me is that there was a company that had to pull off about 10 million rapid antigen tests because they just didn't work, and they had a lot of false positives. In general, though, false positives are a lot less common than false negatives. False negatives continue to be a challenge during Omicron. On the science table, we released a briefing that talked about how with the onset of Omicron a year ago, or more, was just around a year ago, the rapid antigen test became a lot less sensitive, and you had to repeat them many times, and often going 2 to 3 days into an illness before they would actually go positive. So they continue to be a useful tool, but one that's subject to what all of we physicians are familiar with, that there's no such thing as a perfect test.
Thank you so much. Next question is related to risk factors, and the person asking the question is commenting on the fact that more than 6 months since the COVID vaccination is a very, very large heterogeneous group. Was there enough statistical power to analyze which subset of people in that group is most at risk?
Yeah, so the 6 months interval really is taking a general population view, and probably can be applied to most young and healthy people. When I say young, you better be under age 50 and healthy. And if you are, then 6 months from your last vaccine dose or 6 months from a COVID illness is entirely reasonable. And we know that if you give the vaccine within that period of time, it's not that it does anything harmful, but you don't really get much of a boosting effect. If you take out of that, though, the groups that have high risks for severe outcomes, whose immunogenic response to a vaccine can actually be impaired, and that actually happens in older people, not just unhealthy people or people who have existing immunocompromising conditions, then the interval between vaccine dosing or after of an episode of COVID before you get a vaccine booster probably is much shorter, and could be as short as 3 months. Right now, NACI is sort of saying about 3 to 4 months is a reasonable interval. So young and healthy, 6 months. Not so young young and healthy, think about 3 to 4 months before your next vaccine dose. And if you've had COVID, when you get your next vaccine.
Great, thank you. The next question relates to the vaccines, actually. So this question is, does Moderna have a BA.5 bivalent available in pharmacies? And is there any superiority between Moderna versus Pfizer?
So the first question is, Moderna has approval for its BA.4/5 bivalent. And in fact, many of you have already had a bivalent and you got the Moderna, you probably got that one. They did release a BA.1/2 bivalent earlier on, which actually showed some pretty impressive protection even against BA.4/5, but they do have a BA.5 that's out there. As I've seen, unfortunately, as you would imagine, we don't have direct comparisons between Moderna and Pfizer. What we have would be indirect comparisons. If you look at indirect comparisons, and if you look at neutralizing antibodies, and I'll make a quick point that neutralizing antibodies have now been shown to be a very effective and useful surrogate marker. Remember, it's a surrogate marker, but it actually correlates well with protection. Then the 2 bivalents from Pfizer and Moderna look pretty well the same.
Thank you. So our next question here is commenting on the reliability with the rapid antigen tests, specifically with the current variants. Is there any issues at all with them not being as accurate?
Yeah, there was actually the CDC and MMWR just released a little bit of a report on some of the tests having a really poor ability to detect these new or sort of evolving subvariants that are out there. And they were recommending, and most of them I don't recognize as being Canadian available. They look like they're US rapid tests. But the ones that we use here, again, just with the caveat that they're just not as effective as they were during the pre-Omicron era, they still are fairly effective. For those of you who know me, you can probably hear a bit of a croak in my voice. I just had COVID. Yeah, ID doctors get infected too. But when I did my rapid test, it went positive pretty darn quickly. So, that's an anecdote, and I apologize for using an anecdote to express my opinion here. But right now, the currently available tests in Canada, again, not quite as sensitive, but I think they're still reasonably reliable. Just remember, you may have to do it more than once and probably a couple of days into your illness if you develop symptoms, to make sure that if it's negative, it's really negative.
Thanks so much. Another question pertains to the vaccine. So how effective is the pediatric Pfizer bivalent booster against the XBB 1.5 subvariant?
Yeah, we don't have a lot of data on kids in particular, but I did show you that there is some published evidence now that neutralizing antibody responses against XBB.1.5 are significantly increased with the bivalent boosters, and for particularly BA.4/5. The only thing I can tell you about kids is that kids have excellent immunogenic responses to vaccines, and that's been seen again in the use of the mRNA vaccines in younger kids. So my expectation, I would extrapolate, is that they're probably going to have an increase in protection against these newer and emerging subvariants like XBB.1.5, because it's certainly in a large, broad look at adults that have been given vaccine, it appears to increase those neutralizing antibodies.
Thank you. And then the other question I wanted to ask here, I guess going back to the vaccines, is regarding the Moderna BA.1 bivalent. So I know we had talked a bit about the BA.5 one, but for the BA.1 bivalent vaccine, do we know about what protection that would offer in this current environment?
Well, when they did that, so Moderna, because they made a BA.4/5 and a BA.1/2 bivalent, actually looked at the comparison between their neutralizing antibody responses, and they actually showed that they were pretty well exactly equivalent. So in other words, they weren't statistically different when you looked at the neutralizing antibodies produced by the vaccines out at about 30 days. So right now, I think the most of the supply is actually the BA.4/5 one, but if you got the BA.1/2 back in September or October, you've got pretty good protection. That looks, at least in a direct comparison that the company did with their 2 vaccines, to be somewhat the same. Although I will point out that those neutralizing antibody responses were seen in mice. So they weren't, they did measure them and they have human data, but the data on the actual production was in mice. And so you have to take all your caveats that there is a difference between mice and humans.
So the next question here is regarding some of the hospitalization data here. So in the last 4 months, PHO hospitalizations due to COVID have been clustered mainly in those over 80, and even more so in unvaccinated elderly patients. Assuming we all keep up to date with our vaccines, has severe COVID become mainly an elderly and immunocompromised patient issue?
I would say yes. And I agree with that observation that, when we look at, I've been, we track our hospitalizations here where I am in the Southeast amongst, of course, where I work at Kingston Health Sciences Center, but a number of the other regional hospitals. And it has been primarily during the fall driven by elderly individuals, principally those over 80. At one point, we were looking at an average age of the hospitalized people in the Southeast region with an average age of 79. So that's driven mostly by that. And when you see it in a younger person, as was mentioned, it's typically someone who may have had a poor immunogenic response, or where COVID actually initiated a worsening of an underlying disease that was already there. We're all familiar with that. Before COVID came along, when you saw flus and rhinoviruses and stuff, they exacerbated underlying conditions. So again, that's the major contributor, but that is an observation, and I think that's well taken. And we are starting to see, we're never going to get herd immunity because coronaviruses are really tricky and they don't leave you with a permanent immunologic response that protects you forever. But we are starting to see that transition of this virus from a pandemic virus probably to an endemic virus. And we'll see that when we start to see test positivity levels that during the winter season are persistently at about 5% or less. And right now it's still behaving a bit like a pandemic virus. We've got, test positivity, as I showed in that one slide, that usually hovers right around 15%.
Thank you so much. So for the next question, I'm going to combine it with another question that I received here. So it was related to the booster dosing of vaccines and whether or not healthcare providers should be getting boosters every 3 to 4 months, regardless of age. And I'm going to combine that also with a question around some of the recent statements that have been coming out from NACI saying that there's going to be some, weighing in regarding the future of boosters, and curious to have your opinion on that, both for healthcare workers and for the public.
Yeah, so lots of real interest. I mean, is sort of the idea is boosting a forever strategy? Is boosting potentially at some point not going to offer the benefits it has? So one of the things that would argue very strongly against healthcare workers having more frequent booster shots or the interval between shots being less is that we've got very good studies in young healthy people that if I give you a booster shot within 6 months, sort of within that window from your last booster shot, the increase in neutralizing antibodies is actually very small and almost undetectable. So it's important to remember that when you are mounting an immune response to a vaccine, after you get the vaccine, your immune system continues through a process of adaptive affinity to refine the antibodies that are produced against the antigen that was presented to it. So in fact, that process probably goes on for at least 3 or 4 months before starting to settle down. So immunizing somebody with another shot in that period of time just isn't adding anything to it. And in fact, it's not giving you the same quality of response that you get from that B cell adaptation to refining an antibody to get more avidity for the antigenic target. And that's an immunologic principle we know about and have known about for years. So I don't think it argues for more frequent shots for healthcare workers, especially those that are young and healthy, which is the majority of our workforce at the moment. So I wouldn't do that. But we are still going to be having to sift through data for the next few years about all of the boosting we've done and looking at very large population studies. We are involved in one here looking at serological responses and stuff in a large group of people with and without COVID to sort of see what that effect had, because in a weird way, we're kind of, with the mRNA vaccines, we're still moving in the direction of recognizing that we do seem to need them about every 6 months, especially during this pandemic phase, but we may not need them as often anywhere near that once we get into a phase that's not pandemic.
Great. Thank you so much. And I guess, this kind of dovetails a bit with this question around, whether or not people need a 6th dose or suggested 6 months after the 5th dose in terms of like the amount of doses of the vaccine. Would you be able to comment on that at all? Whether people need to just keep kind of getting these boosters every 6 months and go for the 6th dose?
Yeah, that's a great question, Ali. So one of the things that has been talked about is this sort of chasing the variant phenomenon with boosters, because even now the vaccine companies, including the Novavax vaccine, which probably some people may have had, but very few, they're looking now at an XBB.1.5 bivalent vaccine. So the question then becomes is, do we get, and I've shown you there's a distinct advantage with some of the new subvariants with the bivalent vaccine, but at what point do we lose that advantage? And in getting boosters into people with the older bivalents, are we missing the opportunity for a newer bivalent that comes out, especially if there's a new variant that would arise, for instance, with the large increase in cases we've seen in China? So that's really the crux of the matter of whether or not you get 6 or 7 shots at all, because at some point we have to make a decision about, you've got an optimal response. We're not seeing an incremental gain with a newer bivalent booster. And so why would we do anything other than just, consider maybe twice a year boost until we're out of the pandemic for the vast majority of the population?
Great, thank you. And maybe I'm going to go for one last question before we move on to the next speaker. And so this one is asking a little bit, getting back to the variants. So since the upcoming variant XBB.1.5 is more related to the BA.2 variant, why isn't it that the first generation of the Moderna bivalent vaccine isn't preferred?
Yeah, so although it is derived XBB.1.5 from 2 BA.2s, it's sufficiently different from BA.2 that there would not be an expected advantage necessarily from the older Moderna bivalent, which included BA.1 and 2. And again, most of the analysis on XBB that I showed you from that table have been done with the BA.4/5 bivalents, not the BA.1/2. I could probably pick a little bit at Moderna and see if they would give me data to show whether or not the BA.1/2 bivalent has better activity against XBB.1.5, but I haven't seen that data, and I'm not even sure if they have that data to be able to show us and see if that's a thing. But it's an interesting concept given that it's derived from a BA.2, but it is a recombinant, so there's a lot of mutational changes that occurred when the 2 BA.2s recombined.
Great. Well, thank you so much for answering so many questions in rapid fire like that. So thanks. So I'm going to turn things over to Dr. Kieran, who's going to moderate the next portion of this session. And if we can just pull up the slides again.
Thanks so much, Ali, and thanks, Gerald. It was a great informative session. I'm just going to highlight a couple of things that came into the chat as well. So you may have noticed that Fareen Karichwala has made a few comments into the chat. Fareen is actually the Associate Chief Medical Officer of Health in Ontario. And so she's very involved, obviously, in vaccination and Paxlovid policy. And so she's probably going to continue to chime into the chat. But one of the couple of comments I just wanted to highlight of hers, she did mention how the Moderna BA.4/5 is approved, but most of the supply in Ontario right now for Moderna is the BA.1. She also then had a great comment here just about that dosing interval, which I know is confusing. She said NACI is starting to emphasize that the 6-month interval post-vaccine or confirmed infection is most optimal. The 3 months that was there in the October statement was mostly to get people caught up prior to the fall. It wasn't intended to be an ongoing 3-month interval. So just to clarify that it's, we're really thinking about 6 months intervals, it seems, for people getting their booster doses. And then to that effect, we wanted to just highlight these great resources that are been developed by the University of Waterloo team that are great resources to discuss boosters with your patients. So yeah, with that, I wanted to move on and we're going to switch topics now because we also know that there's lots of questions about Paxlovid specifically and therapeutics more broadly. And I'm just going to go to the next slide here. Yes, thanks, Olivia. And I'm going to introduce Andrew Pinto to go next. So Andrew and his team are doing an incredible national trial that's going to help us get actually the evidence that we need to be able to practice more confidently and actually have the answers to many of the questions that are being asked in the chat. So I look forward to hearing your summary, Andrew.
Thanks so much, and thank you, Gerald, for a fantastic presentation. I just want to introduce some of the team members here who will also be speaking with me and answering some of your questions. Dr. Christy Kostanian has been answering a number of the questions in the chat. She's been helping stay on top of the emerging evidence around treatments for acute COVID. Dr. Benita Hosseini, who introduced herself, is a research scientist with us at the Upstream lab and really playing a key role in this. And Norm Umali is a clinical pharmacist who's going to be speaking after, and he's part of our team as well. We also have Gail Astorga, who is helping support engaging family physicians in this study as well. So next slide. So I can kind of summarize what we're doing here with this large adaptive platform trial in kind of 3 points. One, which came up, is that unfortunately COVID is going to continue to be with us. It's a virus that is novel, but is likely going to be endemic, similar to influenza. So it's going to be here with us. And that's partly why we need to have what are called adaptive platform trials, which are persistent studies that kind of continue ongoing as long as the issue is a threat, to test different treatments in this case. So the second kind of main thing is that we unfortunately still don't have great evidence on what works to treat acute COVID, and that's what we're going to be trying to figure out. And the third is that now that with a highly vaccinated population and variants that are still problematic but not leading to huge numbers of hospitalization, COVID is really a primary care challenge where we're going to be the ones seeing people with COVID. And really, this is where the evidence needs to be generated, where we need to come up with the solutions that are going to really inform our care. So Can Treat COVID is, as the title suggests, it's a national study. It has launched this week in Ontario. We're really excited, but it's involving many provinces across Canada. It's funded by the Canadian Institutes for Health Research, as well as Health Canada, with support from the Public Health Agency in terms of the actual medications. And so this is a really unique case where we don't have pharmaceutical industry involvement. So we're really fortunate to have funding from the government to do this study and to do it in a really rigorous way. Next slide. So we're doing this because most of the research that has focused on treatments for those who have COVID have been focused on those who have been sick enough to be admitted to hospital. But really, because this is now a common outpatient concern, we need effective treatments, we need evidence around it. Most of the existing studies, including some of the pivotal studies that have led us to prescribe medications like Paxlovid, which we're going to talk about, have been in really unvaccinated patients. It's unclear whether and to what extent existing therapeutics are effective in partially or fully vaccinated patients. And currently, no therapeutic has specifically been looked and found to reduce the likelihood of long COVID, which is going to be a really massive concern in the years to come. Next slide. So what we're trying to do with this project, which we hope to engage many of you in, is understanding what's the effectiveness of different COVID therapeutics, and are they cost effective? Because some of them are super expensive. Is it a great use of our resources? How does this differ by people of different risk group, whether it's vaccination, age, or other characteristics, and across diverse populations? And finally, do any of these treatments reduce the chance of people developing long COVID? Next slide. So what we're looking at is using a randomized trial approach, which will have multiple arms over time, is comparing usual care, which is where people, are infected and receive general supportive measures, versus both existing and novel treatments for COVID in primary care and outpatient settings. Next. So who could be eligible for this study? Probably many of the patients that you're thinking about. We have quite a broad kind of set of inclusion criteria. One is that they do need to have a positive test. It can be RAT or PCR. And usually we need to have a picture of that positive test. They need to have symptoms starting in the past 5 days. And this is probably one of the most crucial parts is if people, develop symptoms, 2 weeks ago or 3 weeks ago, it's just going to be too late. But if someone has developed symptoms in kind of the first couple of days and they're reaching out to you or us with the study, they could be eligible. And finally, it's everyone 50 years and older and anyone who's 18 to 49 with one of many pre-existing conditions. Next slide. So these are the list of conditions that are there, and you don't need to note these at all. They're also on our website, which is cantreatcovid.org, and we'll put that in the chat. And we'll also come back to that. But it's one of many, many different pre-existing conditions. One of the reasons we've selected these is they do match a lot of what we have been told to think about in terms of pre-existing or chronic conditions, but also it allows us to compare our results and pool them with colleagues in the UK who are running a very similar study. Next slide. So some things that would exclude people is if they're admitted to hospital, they're an inpatient, if they've had to be admitted to an emergency department for more than 24 hours, obviously if they've already been part of the study, or if they're part of a different study, or if they're already taking one of the study drugs that we're studying, or if they can't give consent. Next slide. What does it involve? Like if you had one of your patients who connected with us and got involved, they would have a detailed assessment, including having a staff review how they're doing and their eligibility, and also a clinical pharmacist, and Norm's going to speak to this, who actually goes through all of the questions about, are they eligible for a medication? Are there any contraindications? The study is being conducted completely remotely, so people can be anywhere in Ontario, and we'll be mailing the medication directly to them. And the medication is provided through the Public Health Agency of Canada. What participants will need to do is we're asking people, of course, some questions at baseline, but then asking them to complete a very short daily diary for 14 days, and then also follow up with us over the phone. We also are having options where people can complete the surveys online as well to just check in how they're doing. Next slide. So our first treatment arm, and because this is an adaptive platform trial that's going to have multiple arms over time, an important point is CanTreat COVID is going to go beyond nirmatrelvir, ritonavir. It's going to really be involving a number of different medications. Next slide. So some of you may wonder, what was the rationale for starting with this medication, which is already already being used, and there is some evidence. What we have done is, by looking at the existing evidence, it really does appear that the safety and efficacy of this really needs more study, that there is uncertainty around this medication and how effective it is, particularly with current variants that are now circulating. And also, a lot of the most recent literature has been observational studies, which have indicated that there's maybe some benefit of this medication, but really the only randomized controlled trials, which would really not have the same bias as those observational studies, were done way back when we had lots of people who were not vaccinated. There's also no evidence as yet on the effects on long COVID. So that's part of why we're studying this. And also that study in the UK that I mentioned, Panoramic, we'll be pooling our data with them to really try to answer these questions, which require these really large sample sizes. Next slide. So in the future, what we see is that some people put in the chat, what about Paxlovid for 10 days? What about other treatments? That's something that there's a lot of interest in studying. Some of you may have also seen recently, again, some interest in metformin for acute COVID as well. So this type of platform allows us to evaluate multiple interventions. Next slide. So you may wonder, why would I refer somebody who comes into my office or who contacts me and has COVID? One is we do think this will save family physicians time. You can refer people who are tested positive and be sure that they will be screened and have an assessment done. If they're eligible for the study, they may be randomized to receiving Paxlovid or one of the other arms. It's also this study and this platform study that we're conducting is going to be the fastest way to really answer whether or not these medications are effective, particularly in a highly vaccinated population. We all know kind of the story around medications like Tamiflu, which when they first came out, they seemed like they were super effective and really great, but then subsequent research found that they were not that effective. So this is going to be having these types of adaptive trials are going to be really key. And then finally, this is by family physicians and for family physicians. And as I mentioned at the start, we really need to develop this evidence within the places that we work. We also are using this as an opportunity to launch a new Canadian primary care trials network to really finally, engage all of us in creating the evidence that we make use of, working closely with respirologists, infectious disease specialists, and many others to build this. Next slide. So how do you refer patients? Really straightforward is remembering our website and maybe bookmarking it and sending folks there. We do have a 1-800 number. We also have an email, and on our website we have a form. We're also going to be advertising this through social media, through regular media, through infectious disease clinics, emergency rooms, and many community organizations as well. So hopefully patients are hearing about this through multiple ways. For those of you who are part of existing practice-based research networks in Ontario, we're also going to be approaching you through that in terms of actually proactively sending letters out to patients who could be eligible using the data that we have from those networks. So please, do think about referring any patient who has a positive COVID test for this. Next slide. And I think this is the last, is really, really open to questions about this and kind of why we're doing the study, how you can be involved. And Dr. Hosseini and I will try to answer. Norm's going to be speaking next and talking a bit about the role of a clinical pharmacist with this, and also kind of the perspective of a pharmacist as well. Thank you.
Thanks so much, Andrew. I'm going to just go right to Norm, actually, who can talk a little bit about his role in Can Treat COVID, and then we'll go to questions and discussion, because there's certainly lots of discussion in the chat as well as a lot of questions.
Hi, everyone. So I'm going to do the third leg of our relay here. Again, I'm Norm Umali. I'm the pharmacist working with Andrew's team on the Can Treat COVID project. So seeing as nirmatrelvir ritonavir is our only outpatient treatment, we should probably just review quickly how people in Ontario can get this medicine. Access involves the clinician assessment and then the patient acquiring the medicine. In Ontario, there are many COVID-19 assessment centers. If you go to the Ontario government website, included in this list are places such as even primary care clinics, as well as what we're calling here in Toronto as hubs. These are like pop-up style sites where people can get tested, and they can also get assessed for nirmatrelvir ritonavir. In early December, the Ontario government added community pharmacies as having the ability to assess and prescribe as well. But while there are 4,000 plus pharmacies in Ontario, I'm not aware of a central list of where you can access names or locations of pharmacies which are providing this service. I recently went to a website of a large national chain, and there is ability to make an online appointment for various pharmacy services. And on that website, I could not make an online appointment for a COVID-19 assessment. So I do expect that the uptake will take some time. Regarding distribution of nirmatrelvir ritonavir, when your patient goes to get this prescription filled at the pharmacy, or if the pharmacy delivers it, they will not have to pay for this medicine. As well, pharmacies do not have to pay for the medicine either. So there should be no issues with maintaining stock or just keeping a few boxes of Paxlovid on hand. So nowadays, actually in early days, only a few pharmacies were carrying Paxlovid, but I can safely say now that most pharmacies have some supply of Paxlovid available. Next slide, please. So when having the risk-benefit discussion, we should probably know the adverse effects that we can expect to happen. We want to know the likelihood as well as whether or not the side effects would be even serious, whether they're or if they're unlikely. And then if our patient will be at risk of more serious side effects based on what we're anticipating. So the product monograph lists these side effects. And at first glance, they actually seem pretty manageable. So for a usual risk to benefit discussion, I would anticipate that most patients would want to proceed with treatment with nirmatrelvir ritonavir. I would say that the hypertension side effect is probably the most noteworthy. Next slide, please. So while the clinical assessment is comprised of several steps, including going through a long list of comorbidities to assess eligibility, probably the most intimidating step is managing the drug interactions of nirmatrelvir ritonavir. So I'll be honest, the drug interaction list is intimidating and confusing. Contributing to this confusion is the inclusion of medicines which are no longer easily available in Canada. Medicines such as cisapride and estemazole. I mean, these medicines haven't been around for probably decades in Canada, but they're still included in the list for the sake of some people just having personal supplies. The ritonavir is a culprit component, and while ritonavir is being leveraged in this treatment to boost up the nirmatrelvir to therapeutic levels, this is the same property that's at the root of possible interactions. So it's a long list, and if you're accustomed to using lists as references for drug interactions, but you find this list difficult to use quickly, I would suggest using the Liverpool Drug Interactions online checker. This tool is a good reference. All the local Canadian guidance refers to this tool as well. I find it really helpful as it's the most up-to-date. It provides management strategies regarding specific interactions. So it doesn't just identify the interaction, but it tells you how you could possibly manage it to make it safe. And I also believe that there's an iPhone app as well. And not unusual, managing the drug interactions for older adults with multiple chronic conditions as well as multiple medications will indeed take more time. Next slide, please. So medical screening, drug interaction management, patient counseling, and follow-up are my primary roles with the CanTreat COVID project. So when you refer patients to CanTreat COVID, I may be the one reaching out to you to clarify some of the medical history. And lastly, I just want to leave a quick parting comment, only because it's a source of confusion, and I thought I'd clarify it. So nirmatrelvir ritonavir treatment must be started within 5 days of symptom onset. And we count day 0 as the first day that symptoms appear. Thank you.
Thanks so much, Norm. So yeah, I think we'll, maybe I'm going to go to the next slide, a couple of slides, just to make sure people have some new resources that are out there. Wanted to highlight that. So Andrew and Norm are going to talk more about this, have highlighted, of course, CanTreat COVID, which is a way that you can get access to medications for your patients while also furthering science and helping us as clinicians know in the future what to do. If you are ending up to prescribe yourself, this is a wonderful new resources that's been put together by the Ontario College of Family Physicians and the Centre of Effective Practice that helps just decision-making around Paxlovid prescribing. I'm going to go to the next slide. The next slide is just a a reminder of a great resource from the eHealth Center of Excellence. So this is helping you to understand who in your practice might be eligible for Paxlovid and easily prescribing Paxlovid within your EMR. So I'll just end slides there for a moment and we'll do some Q&A for the next 10-15 minutes. And maybe I wanted to just start actually though by acknowledging like a chat that's been happening while Andrew and Norm have been talking as well, just about whether Paxlovid is something that physicians can pre-prescribe or not to people who are who they're worried about, who are vulnerable. And it does seem that there's a difference of opinion. So I think we have an individual who works with the Ministry of Health, Jason, who's put forward that in his opinion, he thinks physicians should be able, or NP should be able to write a prescription for a patient and have it on file in the pharmacy. The pharmacy wouldn't be able to dispense until the test until a test is positive, but that file should be able to be should be able to be there. But however, there are many physicians who are saying that pharmacies are providing pushback around that and that they haven't been able to do that. So just to let you know that we're going to try and get some clarification on those points so that we understand what is possible or what is not. I don't know, Andrew or Gerald, if you guys have any insight into that and if you wanted to speak to it. I also do, though, I do wanted to highlight that, you know, what the other thing that's been happening in the chat and the Q&A is people often talking about vulnerable patients who they're worried can't access Paxlovid in different times. And Andrew, I wonder actually if your trial is a way for people to actually have almost like a safety net of access. I don't know if you want to speak to that.
I'm happy to speak to that. And indeed, a big part of our project is trying to engage communities that have been made vulnerable by social and economic policies and really ensure that this is reaching a diverse group of folks. We have dedicated staff who are focused just on the community engagement. So indeed, and a really important point for everyone is people can self-refer to this, that it doesn't require a referral. We see, you know, all of Ontario's primary care providers, including nurse practitioners and family physicians and many others, as key to helping spread the word and suggest this to people, but people can self-refer on their own. And we expect a lot of people will do that because they may be symptomatic and then, you know, just learn about the site via, you know, a Facebook ad or some other thing, or see it on the side of a bus and say, you know what, I want to take part in that. Yeah, and thanks for Benita has put in the chat. There's no cost for participants. There's no cost for the medication. And in fact, there's an honorarium for each encounter, each study to help compensate people for their time.
And so just to clarify, so a physician can refer, a nurse practitioner can refer, a patient can call, a family member can call, and the study is ready and able to assess them and dispense medication today. So
that's right.
Very exciting.
That's right. We launched on Monday. We wanted to do it before this event because we knew this was a great opportunity to reach hundreds of Ontario's primary care community. And so we are able to. Yeah, I should say that it's the cost, as I said in the chat, it's covered by the Public Health Agency of Canada, which is all of us as taxpayers. It's a really important point, but the participants, you know, don't face any fee for it.
And so an important point though, Andrew, around your trial is, you know, it is a randomized control trial. So if we refer a patient, it means though that the patient may not get Paxlovid, is that right?
That's right.
And how can we, versus if we could just prescribe it if they met criteria. So why should we refer if we're not sure if the patient is actually going to get this drug and we're worried about the patient?
I think like many things, first it's that we would explain this to participants really clearly, that we're seeking to see does this medication and also future medications that we study, does it have an impact? Does it really work? And that right now, we're not sure. Does it work? A lot of the studies that were done in way back in the pandemic in a mostly unvaccinated population. And so is it really worth it? Also, you know, so participants would understand that before they engage with it. I think for what we've seen here, and part of the discussion is I think clinicians really see that there is some uncertainty with this medication, but also we want to see how does medications like Paxlovid compare to other things. So as this is up and running, because COVID will be persistent with us, unfortunately, is we're going to be testing and comparing, say, Paxlovid to others. One of the points people made is, what about Paxlovid for 10 days? So that's something that we're thinking about doing. But we also have ideas about studying, things that potentially are much less expensive, like nutritional supplement and antioxidant therapy and other types of treatments that come along.
And so just wanted to clarify too that, your study is province-wide. Anybody, it's not in Toronto physically, it's province-wide. So the pharmacy is virtual. And in fact, they're going to talk to Norm or Norm's colleague and virtually on the phone, and Norm will send them the Paxlovid in the mail. Is that right? So it actually has also the benefit that the patient doesn't have to go to a pharmacy and navigate that. And maybe you can tell me also, Andrew, is your phone line open like 24/7 or just sometime?
Right now it's between usual operating hours, kind of roughly between 8 to 6. We would follow up with people too if they leave a message. So we would make sure we follow up with people if, say, they call in the late evening. But indeed the process is, person has some symptoms and they have a COVID test that they do that's positive, and then they reach out to us, or they connect with their primary care provider, and then they're referred to the study, and then they would speak right away with a staff member who tells them about it, make sure they understand. They would go through a clinical pharmacist review and then be randomized, and within that day, then a courier order is sent to send them the medication in the mail.
So it sounds like they'll get the if they call between 8 and 6, just to clarify, is that Monday to Friday, or Monday or Saturday and Sunday? Okay.
It's Monday through Friday right now, between 8 to 6, but also we'll be following up with people. So they're, we're aiming to be as accessible, but also not place a huge burden on staff. But that's the hope for it, and to have very short turnaround in terms of those who are randomized to an intervention to get it to them as soon as possible.
Yeah, so it sounds like Benita was saying within 24 hours, hopefully they would actually, so if they called during the business hours, they would get the Paxlovid hopefully within 24 hours. So it would be very quick. And I think people were asking about homebound patients, long-term care patients. I'm assuming that all of those patients are eligible as well.
People who are homebound, absolutely. People who are formally institutionalized, like either in a hospital or long-term care, are not currently. So we're really seeing this for the majority of people who are in the community. But so if you're either hospitalized or in an emergency room or something like that, it wouldn't be eligible.
Got it.
And I see a really great suggestion to send people like an email just about Can Treat COVID. We definitely can work with everyone. We also are creating a system for people to sign up if you'd like to receive a package, like with a poster or an information to be sent to you, we can do that. Or if you just want to just be updated on the course of the study in terms of what arms are happening, how things are going, you can let us know.
And I think people were also wanting a script for their medical office assistant to be able to talk about this with patients, as well as obviously posters and materials for their patients, as well as posters to send to colleagues. Gerald, you made a really great comment in the chat, and maybe I can ask you to just expand on it, because I think you were really one of the people behind some of the new updated Ontario health guidance. And I think but at the same time, I think you recognize the limitations of the evidence and the importance that this trial kind of brings, and maybe you could speak to your perspective on that.
Yeah, sure. Thanks. First of all, I mean, I think the work that Andrew and this group is putting together is incredibly important. Everyone knows there's a hierarchical evidence list, and an RCT is going to be much more informative, really, than what we currently have. Now, having said that, the observational data we have, and it's in preprint at the moment from Ontario. My colleague Kevin Schwartz was part of the group that did that, but we've got some observational real-world data from Hong Kong, from South Africa, and a few other places. That observational data suggested that a more permissive role for Paxlovid would be helpful in reducing some of the severity outcomes that we were looking at. And of course, it's more profound in the elderly, where that signal's huge. But there was a suggestion that in other groups that were younger, but who had pre-existing conditions that would predict the likelihood of a more severe outcome, could benefit potentially. At the same time, we had of course, the huge hospitalization crisis that we all just saw through the late fall into the winter, and we're still kind of experiencing now. We were projecting that we were going to see a midwinter rise in COVID. And so that in general, and the fact that, I hate to say this, but the province just has a hell of a lot of Paxlovid sitting around, all sort of led to the concept of a more permissive role. But I would really encourage you to look at Can-Treat COVID. I think that's where I want to use the expression, that's where the money lies, but actually it's not where the money lies. But it's where we're going to get the best evidence, because I think very appropriately so, some people were skeptical about that permissiveness that we allowed in the most recent Ontario Health recommendation on Paxlovid. And yes, you can blame me. I was the guy who chaired the group that looked at all that sort of stuff. But essentially, when you're weighing all those factors together, it sort of made some sense, but we could be wrong. And what Can-Treat COVID and trials like that are going to tell us is, were we right or were we wrong? And I think that's really important, because as Andrew stated, and I can't say it enough, we're not out of this yet, folks. And somebody asked me a question in the Q&A that I put in there, and they said, well, when is this all going to be done? So I'll give you my prediction. Somewhere between 3 to 5 years from now, we'll be out of pandemic and into the endemic world. But this transitional period is actually going to be quite long. For those of you who are students of history, Spanish flu, which everybody says, oh, that was 1918, 1919. The last pandemic wave of Spanish flu occurred in 1928. In other words, almost 10 years after Spanish flu was first described as a pandemic. So this is what happens to viruses. They work their way through. These zoonotic viruses essentially transition into the human population as a niche population, and it takes us some time to work that into an endemic thing by raising immunity in the population, by some hopeful change in the frequency of mutations that are seen because less people are infected. If you don't infect a lot of people, you don't generate a lot of variants and mutations. The virus only mutates when it reproduces. It only reproduces when it's infecting something, like a person or a mink or a deer or a cat or a dog. And by the way, dogs get COVID, but they don't transmit it. Cats get COVID, but they do transmit it. So yay, us dog owners. But that's the real key here. So what Andrew's proposing in that RCT is really important, because it'll also inform us how we fit and look at other upcoming therapeutics. I could tell you there's at least 3 or 4 good candidate experimental antivirals that are coming up the pipeline. But we got to know where Paxlovid sits there, so that if we're going to use it as a standard of care to compare these other ones, we know what it's going to do.
That's a fantastic summary, and thanks for your endorsement too, Gerald, with this. I think it's just, as you said, we know there are many other treatments coming down the pipeline, and that's why we need these types of platforms. We all wish we had this set up, years ago, and now is kind of the time to get it ready, because this is going to be with us. I just want to answer the question again about placebo or people. So the important thing is we see that there is a need to do this study, and a need to really see whether or not, whether it's Paxlovid or other treatments are effective. Because we're really closely monitoring people and telling them you could be, randomized to usual care versus one of the treatment arms. People are going in with that understanding. And the thing is, this is engaging the population too in helping us see what works. And actually, we think a lot of people will want to do that, to really say what works for for COVID, and also what works to reduce long COVID, which is a huge concern, I think, for a lot of folks. In terms of the number of participants, it's a large study. It's actually about 2,500 in each arm that we're seeking. So that's why it's a national study. And we also will likely be pooling what we find with our colleagues in the UK to really solve this question around different arms. And yeah, it's been great to be able to talk to you about this, and to also kind of like, say this is a great opportunity to create evidence that's going to really inform our practice.
So I think there are some other questions. Just to clarify again, you don't need an OHIP card to be in the study. I believe that you can refer to the study just by calling the number or asking your patient to call the number. They are following up patients. And Andrew, maybe you can just clarify if a patient deteriorates, are you doing an assessment? Because
maybe I'll maybe turn to Dr. Hosseini. Do you want to just go through kind of what the assessments are for people?
Yeah. So in terms of the study assessment, before they randomize, we just go through their medication list to make sure that they are not taking any medication that has been contraindicated with Paxlovid. And once they're enrolled to the study, they need to complete a patient's diary online from day 1 to day 14 to just let us know about the severity of the symptoms. We do also have safety calls at day 1 and day 4 to make sure that there is no adverse event for the participant as well. But we also follow up with them at day 21, at day 28, to focus on if they have been if they visited the emergency department or if they are hospitalized for COVID-19. And we also have follow-up calls at day 90 and week 36 to make sure and to see if they are experiencing long COVID symptoms. And all participants, they will reimburse $30 for their time for each of the study follow-up.
And just to clarify though, I think there was a concern that, if someone's not doing well, would you advise them to go to the emerge? Like, because often if they're going to call their doctor, we would give them that kind of advice if we were worried about them. So I don't know, Andrew, if you're able to address that. And I think there's also
all
about how you deal with the renal function and stuff like that. Go ahead, sorry.
Yeah, I'll answer first, and maybe I'll ask Norm to talk about the renal assessment piece. Absolutely all study staff are trained and would direct people to seek care if people need to go to the emergency department or are really sick. And in this case of a study, people are really being closely followed, like really intensely. So we think that that's part of why being a participant in this study would have that kind of safety, protection. So if people needed to go, absolutely, people would be directed to. Norm, do you want to talk a bit about the question about renal function?
Yeah, for the renal function, we'll be screening. We do have access to things like OLIS. So that's part of our assessment, is to make sure that we will make sure that they're safe to take the medicine. That's probably my biggest role.
Thanks, Norm. So yeah, I know a lot of people have some other questions as well. I know Andrew is very focused on ensuring that that there's an equitable approach here and that everyone who needs this care is able to get it. So I know that their team is doing everything to try and move barriers away. I think there are some questions just about people not meeting specific eligibility criteria and whether they would still, not necessarily even in the trial, but I think people are also niggling about different criteria. Nicole, I think you asked about asthma. I noticed asthma was actually explicitly laid out as an inclusion criteria in the trial that Andrew mentioned. So I think that's good news. I think there are some high-risk patients who sometimes don't meet specific things, but I don't know, Andrew, it sounds like Andrew just, their team will do a more thorough assessment to really see whether they're able to qualify. But of course, there is there'll be in the randomized trial, so they would either get it or not get it.
Yeah, and I really appreciate the suggestions about community pharmacists. This is something we are doing actively too, is is engaging community pharmacies and letting them know and asking them also to consider this. Yeah, it's I think a case where people will have a huge amount of observation and also kind of pre-checking before they go down this route as well. I really appreciate the suggestions about vulnerable populations and how are we doing that. Our lab, the Upstream lab, has a very strong focus on equity and reducing barriers for folks to care and to participating in research. So this is something that will be making a big focus, and we have dedicated staff to do things like, what if people don't have internet connection? What if people speak a language other than English or French, and so on, and making sure this is something that people can engage in.
Thanks so much, Andrew. So we're going to just put up our final slides, but maybe what I'm going to suggest is our team is able to pull together some of the Q&A and the chat for you guys. And maybe you guys could put together a little FAQ and we could send that around to all the participants so that they get promotional information. It's clear how they can refer, what will happen when they refer, and then have some of their answers to some of the really great questions that people are asking, both in the Q&A and in the chat. So thanks to everyone. I wanted to, just as we wrap up, just highlight a few things. So one is an opportunity to be part of the Sentinel Practitioner Surveillance Network. We've talked about this kind of opportunity before. It's actually a great benefit to you and your patients, because as you do this, I think you yourself start to understand what's going on in your own practice with your patients. So something to consider. Next slide. I wanted to also highlight that there is updated guidance on the post-COVID-19 condition or long COVID, and our hope is that we will have an upcoming session that focuses on this topic. Next slide. We're excited that the Family Medicine Summit is happening next week. So hopefully you guys have registered and we look forward to seeing you there. Next slide. And I wanted to say that we're always looking for new representatives on our planning committee. So would love to have any of you guys volunteer. You can email us directly. We put an email there on the slide, but just contact us and let us know. We're particularly always interested in people from different regions of Ontario or different practice models, because that then allows us to better plan these sessions to meet everyone's needs. Next slide. So thank you to everybody who participated today. Thanks, Gerald, again, for always fantastic review of what's happening with COVID and a wonderful Q&A. Thanks to Andrew and his team, Norm, Benita, and others, I think Christy, who were all, even when you weren't speaking, answering some questions in the Q&A and the chat. And I want to just thank you for your leadership. It's really amazing to see a randomized trial based in primary care led by family physicians to answer such an important question globally that so many of us really, are counting on the evidence so that we can better practice. So thank you for that leadership. And thanks to all of you for joining us again. And thanks to my co-moderator, Ali. Thanks to Mekalai and Liz for our co-hosting. And thanks to all of you for joining us in 2023. And we're hoping that 2023 is a brighter year than 2022. And looking forward to some new sessions. Our next session is just in a couple of weeks. We always love for you to fill out our evaluation, tell us what you want the sessions to focus on. And of course, our slides and the full recording will be made available later today on our website. Thanks, everyone. We look forward to seeing you again in a couple of weeks. Bye.